All right, well, welcome everyone, and thanks for joining today's webinar, Sticker Shocker, What Employers Can Do About Healthcare Prices, featuring special guest Christopher Whaley. Just a couple of quick housekeeping items before we get started. First, we will be answering your questions towards the end of the session, so feel free to submit any questions you have using that Q&A tool at the bottom of your window. If you can avoid putting those in the chat, we'd appreciate it. And second, you will receive a follow-up email with the recording of today's session, so do look for that later this week. And with that, I will turn it over to our Chief Commercial Officer, Chris Cigarran. Chris, get us started.
Thanks, Krista, and welcome everybody. Appreciate you joining us on a Monday. I guess it's still morning most places, afternoon some. Chris, thanks for joining us. Always good to see you, and appreciate your long-term partnership. I'm going to spend 2 seconds here introducing Chris, who's a longtime friend of the organization, super human being, and I'm going to go through a bio, and we'll tape this and send it to your mom, Chris. So, Dr. Chris Whaley is the grandfather of the RAND report, now in its 5th version, a groundbreaking piece of research that put transparency for employers into the public discourse. He is also fresh out of the Senate Special Committee on Aging. He's an associate professor in the Department of Health Services Policy and Practice at Brown, received his PhD in health economics from UC Berkeley. His research has always focused on healthcare price transparency and market structure, and has been published in leading clinical health policy and economics journals, in addition to the New York Times, the Wall Street Journal, Forbes, and CNN. He's presented results to state and federal policymakers, including Congress, the California State Assembly, Texas House State Select Committee on Health Reform, the Executive Office of the President, the CBO, and the Federal Trade Commission. We're thrilled to have Chris here. He is, as we like to say, on the right side of healthcare, doing the right thing for the right reasons. And so, Chris, welcome. Always a pleasure. We got great turnout today, and a lot of inbound requests about, hey, how do I hear this guy talk? And so thanks for joining us. Just really quickly, just to set the stage, I think, right, I started a meeting a couple weeks ago by saying, hey, guess what? Healthcare costs are going up, right? It's like, no kidding. You could use the same slide that you've been using for the past 20 years. I think, though, as a country, in commercial insurance specifically, we're at a breaking point. And these are just some stats that I think about a lot, and to set some context before Chris dives into the why. Right, 1/3 of Americans taking out a loan to help pay for medical expenses. I mean, we're at the point where it's ridiculous. 38% of adults enrolled in high deductible plans either skip or forego recommended medical care, and over half of insured Americans feel stressed about medical bills and say the stress has impacted their mental and physical health. And so at some point, we've got to sort of declare the system as broken, and try some new things. And Chris is here really to educate us on, what does the data say, right? He is fabulous about not giving opinions that aren't backed up by data. And so what does the data say, in spite of all of the pontification around the country around healthcare and what costs what? He's done a fabulous job of diving into the data to see what's actually going on. And so with that, Chris, I'm going to turn it over to you. Thanks again for joining us.
Great. Really fantastic to be here, and great to talk to you again, Chris. I'm happy to talk about some of our recent work on hospital price transparency. This should say July 24. That's where we are right now. This is joint with a broader team of researchers from RAND, Rosie Kerber, Dan Wang, Aaron Kaufner, and Brian Briscombe. And we were graciously funded by the Robert Wood Johnson Foundation, as well as some participating employers. Next slide, please. So Chris mentioned, where we are in the healthcare system. We've been, collectively working on trying to understand the U.S. healthcare system for a number of years. And as a result of that, the way I kind of think of it is there are 3 economic, facts or points about the healthcare system that I think crystallize the system today. So one, we spend a lot on healthcare, which comes at the expense of goods and other services, namely on the employer-sponsored side, wages. 2, we spend a lot, and the reason that we spend so much on healthcare is due to high prices and not due to mainly higher utilization or sicker population. We just spend a lot because prices that we pay on a per unit basis are very high. And then three, we have high prices, but these high prices are incredibly variable, not at all transparent, and also importantly, not linked to quality of care. And where I think this is particularly important is in the market for employer-sponsored healthcare. So in the United States, employers provide health insurance for about half the country, about 160 million people. Collectively, employers spend about $1.5 trillion on healthcare, with the largest chunk of that pie, just under $500 billion, going towards hospital care. And so, when we talk as researchers or to policymakers about the state of the healthcare system in the United States, most of the focus is at the federal level on Medicare populations and at the state level on Medicaid. But despite being the largest source of insurance in the United States, employers are really, I think, left out a lot of the policy discussions, even though they are an important market. And where I think the market for employer-sponsored health insurance is particularly important is how healthcare is financed from employers. So employers don't have this magic money tree that they can go out and shake when healthcare costs go up. Employers finance healthcare costs directly out of worker wages and other types of benefits. And so if we just go over the last 2 decades, there's been an explosion in high deductible plans. Just nationally, deductibles increased by almost 500%. Employer premiums have increased by about 350%. I'm sure many on the call are aware. It now costs about $24,000 or $25,000 to provide health insurance for a family-sponsored plan, and that money comes directly out of worker wages. And so, if we look at what's happened on the wage side, wages have basically kept up with inflation and have kept pace with inflation. So, if we look, at the United States economy and the biggest source of insurance, the way we are financing the healthcare system is by giving workers pay increases, not in take-home dollars, but in healthcare premium dollars. And so this is incredibly challenging. And next slide. And if we look at what's the source of those increases, as I said earlier, the driver of healthcare spending in the United States is prices. And so if we look across the entire economy, we see that over the last 2 decades, the area where prices have increased the most relative to anywhere else in the economy is for hospital services, with medical services being just behind at number 4. And keep in mind that before we in higher education get too high and mighty, we're at number 2. And I think if you look at this chart, it's not just the case that hospital services are use more technology than any other part of the economy. If we look at places like TVs or new cars, where there's just been a lot of technological innovations, prices in real terms have actually come down. And so there's something unique about hospital services and healthcare in particular, especially for those who receive insurance through their employer, that have just really led to an explosion in prices. And so where I think this is also important is just the role of employers in providing health benefits to their workers. And so, as I said earlier, if you're an employer, the basic way that you finance healthcare benefits is by taking money out of worker paychecks and using that to purchase health insurance benefits and health benefits on behalf of your workforce. And as part of doing that, employers and self-funded purchasers have a fiduciary obligation to be responsible purchasers and to be effective purchasers. And so if you just look at the Department of Labor guidelines on what it is required to be a fiduciary for a self-funded plan, you have to act solely in the interest of your plan participants and with the sole purpose of providing benefits to them. And so that's a pretty, I think, crystal clear definition. But if you're to think about kind of being a responsible purchaser and having no idea about prices, it's hard to see how you could actually fulfill that pretty strong obligation. Where I think this has become not just a kind of abstract policy question, but has actually potentially impacted employers, is something that we've started to see pop up in the last several months or so. So one example comes from an individual who formerly used to work at Johnson & Johnson. and through a high price prescription drug, alleges that the Johnson & Johnson didn't fulfill its fiduciary obligation in having this high price on their formulary and their plan design. And as a result of that, violated their Department of Labor regulated fiduciary obligations. And so this individual filed a lawsuit against Johnson & Johnson. And I think importantly, not just J&J as a company, but also the individuals and the HR executives at Johnson & Johnson who have personal fiduciary obligations. So the fiduciary obligation that requires you to be responsible purchaser is not just a corporate obligation, but also impacts individuals within the company who are making those decisions. And so with that backdrop, that's why we conducted this study. And so just a couple points to make is that, I as a researcher don't know what the right price is for hospital care. That's a market decision, and there's lots of dynamics that are involved there. And I think researchers don't do well when they say this is exactly how much we should pay for given services. At the same time, self-funded employers and purchasers can't act as responsible fiduciaries without knowing accurate information on prices. And so what we really want to do in this study was give employers and purchasers information on prices that are being negotiated on their behalf, and allow them to take that information and combine it with information that they have on their own populations, their markets, and assess whether or not the prices that are being negotiated on their behalf and their workforce is paying align with the value that they're getting. And so just how do we do this? So this is a multi-pronged process. So first, we got medical claims data mainly from self-funded employers. We're also able to get data from now 12 state all-payer claims databases. And so this is a huge resource, and we really got to get a lot of insight into just the whole state market within APCD, and a couple of health plans contributed data. We took all this data, standardized it across the different sources, and then we measured prices in two different ways. So first is relative to a Medicare benchmark. And so this is, I think, the price metric that's gotten the most coverage. Essentially, what we're saying is how much would Medicare have paid for the exact same service at the exact same provider on the exact same day, and then how much are employers paying relative to that price. The advantage of including Medicare is that there are a lot of additional payments that Medicare makes to, I think, appropriately account for differences in cost of care. So some hospitals do lots of service in terms of teaching new residents and having lots of medical education. And so there's an additional payment bump that gets added to those hospitals. Other hospitals are in high cost of living areas, and there's additional payment that's incorporated there. And some hospitals treat lots of lower income patients. And so that also influences Medicare payments. And so if we're measuring prices relative to Medicare, we're incorporating a lot of those different additional add-ons that impact cost of care for a provider. Now, some providers may say that that's great that the Medicare system, or some employers rather may say that the Medicare system, it's great that they have those additional payments, but we just care about the dollar amount. And so we also have what we term a standardized price, which just adjusts for differences in procedural complexity across different providers, and doesn't add in all the additional payments. With this data, we report prices in two main ways. So we have a report that summarizes our main findings. We also have a supplemental Excel data sheet that has prices for about 4,000 hospitals and goes through a bunch of different iterations and cuts on prices. And we've worked with the Employers Forum of Indiana to host the SAGE Transparency Dashboard. And so that puts everything into a pretty, I think, user-friendly way to understand prices. And then finally, we also have a version that essentially cuts down onto an individual employer population and says, this is what prices look like just among your population. And so there's been a lot of work, or pushback as we've been doing this study that prices actually aren't that relevant for healthcare, and we should instead care more about things like value or total cost of care, or those types of metrics that are a little bit more abstract. And maybe not surprisingly, as an economist, I push back a lot on that. In any economic system, prices are the mechanism that we use to allocate different goods and resources. And without transparent prices in market competition, it's impossible to have efficient allocation of goods or services, particularly in the healthcare system. And so in the United States, we rely, especially on the employer and private insurer side, on a market-based economy to get access to care and to fund the system. And so many other countries have decided not to do that. But if the United States, we're going to rely on markets, it's critical that we have price transparency and competition. And then the other pushback that I think we've gotten a lot is that, you know, Medicare sets prices for, you know, the Medicare population, but that's not, you know, relevant to what Medicare or to what employers should pay. And again, we're not saying that Medicare is a price endpoint. We're using that as a common denominator to compare prices across hospitals. So if you see that one employer or one hospital rather is 200% Medicare and another hospital is 300% Medicare, then that's an easy way to compare prices across those hospitals. Medicare, or using Medicare as a benchmark, allows employers to compare hospitals relative to what's the largest purchaser and provider of healthcare services in the world. And I think also importantly, Medicare prices are empirically based and transparent, and have been developed over several decades with lots of input from stakeholders. And anyone can go to the CMS website and learn a lot and see exactly how much Medicare pays a provider. And then finally, Medicare rates are set roughly to be the break-even rate for efficient hospitals. And so it is probably a kind of common denominator to have a benchmark of margin. Next slide. And so if we just look at profit operating margins for Medicare, what we see is that nationally, excuse me, there is a bit of a distribution with some hospitals in the red losing money on Medicare, and in some cases quite a bit. But in the blue, some hospitals making money on Medicare, and in many cases quite a bit on Medicare. And so nationally, the operating margin for Medicare is about a 3.5% loss. And so not exactly break even, but relatively close. And so if you see a hospital that is charging 200% of Medicare, then what that really represents is that relative to the national break-even rate of roughly Medicare rates, then that's a pretty large operating margin profit. And so what we found, just kind of to summarize our results, is that employers are paying prices that are about 2.5 times what Medicare pays. There is a large variation in prices that's not explained by differences in quality or cost shifting. And instead, market concentration really is the driver of prices. And so just to drill down a little bit more into the results, excuse me, we find that nationally, employers are paying prices that are 254% Medicare, but there is a tremendous amount of variation across different states. So in some states like Arkansas, Iowa, and Michigan, hospital prices are below 200% Medicare. While in some states like West Virginia, Florida, and Georgia, employers are paying prices that are above 300% of Medicare. So just across US states, there's almost a 2x range in prices for hospital care that employers are paying. Keep in mind, this is a $500 billion market, and I think it's challenging to find another market this large or this important that has this degree of variation in prices. Also keep in mind that hospitals in Arkansas, Iowa are working well and surviving, and people are able to get access to care. And it's not clear that there's a clear difference between hospitals in those states versus hospitals in states like Florida and Georgia. And so just to look at these a different way, we see prices that really range across the country. And I think importantly, it's not like high prices are clustered in one region and lower prices are clustered in other regions, which would be suggestive of kind of regional differences in pricing or cost of care. Instead, you see that many hospitals or many states that are high price neighbor a low price states, and there's not really any pattern that makes any sense at all. And so I think a good example of this is if you look at the Midwest, where India and Michigan are two very similar states, similar populations, similar mix of industries and geographic bases, et cetera. But prices in Indiana are about 300% of Medicare, and prices in Michigan are about 175% of Medicare. And so if you're a employer in the state of Indiana and you're paying almost twice as much for hospital care as an employer in Michigan, then that's a tax on your operating expenses and doing business in Indiana versus doing business in Michigan. The other thing that we looked at was not just prices for hospital care, but how they also differ based on types of services, and in particular, excuse me, differences in hospital care and non-hospital care. And so we looked in particular for hospital prices relative to ambulatory surgical prices or center prices. And what we know is that in Medicare, Medicare pays ASCs, about twice as much as a same service, or hospitals rather, about twice as much as the same service done in a hospital outpatient department. So if you get your colonoscopy done in a hospital, then Medicare will pay about $1,000 versus if you get your colonoscopy done in a ASC, Medicare will pay a price of roughly $500. And so that's a pretty large difference that's not linked to quality and is really just based on what's the name of the provider doing your service. And so, previous slide. And so what we wanted to look at is what is the difference in, or how does that compare in commercial populations? And what we found is relative to what's already a very large difference in site of care for Medicare, there's actually a much larger difference in site of care for commercial populations. And site of care differentials are actually about half or twice as large in commercial populations as they are in Medicare. Next slide, please. And so we know there's a lot of variation in prices. And again, in our report, we go into the all the differences in prices, but it's important to ask what drives prices. Excuse me. And what we see is that there's no correlation with Medicare, Medicaid, or uncompensated care. And so this is the kind of cost shifting argument that pops up a lot, and I'll talk about it in a second. But we don't see that really actually exists. We find pretty minimal correlation with quality and outcomes, and we find a very strong correlation with market power and concentration. And so just to dive into those in a little more detail, in the next slide, if we just look at cost shifting in particular, this is the argument that we as a hospital just have to charge high prices because we're losing so much money on Medicare and Medicaid. So if that's the case, then what we should see is that the hospitals that have lots of Medicare and Medicaid patients should be the ones with the highest prices, and those that have relatively little exposure to Medicare and Medicaid should have relatively low prices. And so what we did to actually just test that is look at hospitals based on the grouping of the share of non-private insurance discharges. And so this is any Medicare, Medicaid, uncompensated care, et cetera, patients, and their prices on the left-hand side. And so we find is that this line is perfectly flat, and there's no relationship between a hospital's burden of public payers or uninsured payers and their commercial prices. Instead, what hospitals are charging is what the market will bear, and there doesn't seem to be any relationship or support of the cost-shifting hypothesis. Next slide, please. We also looked at differences in quality. To do so, we used the CMS quality stars. And so this is exactly like Yelp, where 1 star is the worst and 5 stars is the best quality. And within each grouping of CMS quality stars, looked at difference in prices relative to Medicare from 100% to all the way up to 500%. And so what we see is that within each quality star, there's a pretty wide range or distribution of prices, and every single quality star has some prices, some hospitals that are priced at 100% of Medicare, and likewise, every quality star grouping has some prices or hospitals that are priced at 400 or 500% of Medicare. And so if you were able to, if we ran the kind of full statistical test of this, again, we find no correlation between a hospital's quality star and a hospital's price. And where I think this is important is that if you were to, or on the previous slide, be a purchaser, this is maybe distressing in the sense that we're not paying for what we're getting. But the maybe more optimistic view of this is that if you're a smart purchaser, then it's easy to find many 5-star hospitals, the best quality, that have prices that are below the market average. And likewise, there are many lower quality hospitals, the 1s and 2 stars, that have high prices. And so if you're able to develop steerage programs or get patients to go to the efficient providers and away from the inefficient providers, then that's a way to both improve quality and reduce spending. Next slide, please. And in other work, we've looked at that in a little more detail and looked at what happens when hospitals raise their prices and the correlation between a hospital raising their price and what happens to that hospital's quality for not quality stars, but for actually pretty specific and important quality measures. So AMI mortality, heart failure, stroke, readmissions, and kind of things that we really want to pay attention to. And across all those measures, we don't find any change, either improvements or decreases in quality when hospitals raise their prices. Where we do find some change in quality is for amenity quality. So when a hospital raises their price, nothing happens on the clinical stuff that we want to be paying more for, but maybe the TV room or the TV in the room gets a little bit bigger. And so we know there's not really any relationship between cost shifting or quality of care, but where we do find a relationship is with market share. And so we looked at the same test and looking at a hospital's market share within their region and their price. And so here, unlike the previous chart, we find a pretty strong increase in prices. And as a hospital gets more market share, they are able to increase their price, and that leads to a huge increase in price and explains a lot of difference in prices. Next slide, please. So how do you gain market share? Well, the most common way in the hospitals industry is just to acquire other providers. And over the last 2 decades, we've seen over 2,000 hospital mergers, which have resulted in a very concentrated hospital market, which we see in the next slide. And so if we look just across the country and look at just kind of the standard definitions that we'd think of as defining market concentration using the guidelines the Department of Justice and Federal Trade Commission use, most markets are incredibly concentrated, either monopoly or highly concentrated. And there's only a handful of competitive markets, and these tend to be in relatively rural areas. And so healthcare markets are probably the most our hospital markets are probably the most concentrated market of any industry that we interact with on a daily basis. Next slide, please. And I think this is important just to look at what are the impacts of hospital mergers. So every study that's looked at hospital mergers have found price increases ranging from about 5 all the way up to 60 or 70%. And then some other work where we find is that hospital mergers over the last decade have led to about a $4 trillion increase in employer spending and about a $1 trillion reduction in worker wages. And other studies have examined the full scope of hospital mergers over the last several years and found not just a no change in quality, but actually a reduction in quality. Next slide, please. And if that wasn't enough, there's a new wave of consolidation really driven by private equity. And so this is certainly impacting healthcare markets as well. And so that's a lot on how much we spend on healthcare and kind of a lot of the empirical analysis that we've done. But as we've been working on this study in this host of studies for several years, it's been really interesting to kind of get out on the ground and to talk to individuals. And as we've been doing that, there's really been 4 interactions that have really stood out in terms of understanding why we are in this system today. And so the first comes from a senior executive at a large nonprofit hospital system in the state of Colorado, whose response to, can you do anything about prices for a school district that was trying to get lower prices for their public employees was, basically pound sand. We reserve the right to charge whatever the market will bear. The second comes from a national TPA representative. And so as we've been doing the study, it's been really great working with many of the national TPAs. We've got lots of great data. But this particular representative, said that, look, we don't find this information valuable, and we don't think our employers will understand it, and we just don't want to confuse them. Again, employers have a fiduciary obligation to understand this data, and now are facing legal challenges on not doing a good job around these types of data. And the third point comes from a benefits director for an employer that had a premium of about $35,000. Again, keep in mind the national average is $24,000, so quite a bit higher. That we just don't know why our spending is so high, but our consultants tell us we're doing good, and we just don't need to worry about it. That is probably not being a responsible fiduciary. And then finally, maybe a little more distressing, comes from a state representative at a state that's doing a good job and has among the lowest prices in the country and has lots of, I think, pretty smart policies, that we just don't want to put our hospitals at a competitive disadvantage, and not recognizing that lower prices or increase in prices are essentially a tax on workers. And so that's maybe a little bit distressing, but I think there's a lot of optimism for what's happening on both the employer and policy side. And so whether employers like it or not, they are in the healthcare business. And I think many employers are recognizing that that is a key component of their organization. Again, whether that's something that they want to do or not. Fiduciary obligations are becoming more real, both through policy actions as well as legal actions. And I think regulators and policymakers have been pretty slow to act, but are, I think, finally moving in the right direction. In the state of Oregon, I think there's pretty smart policies around ownership disclosure. In Texas, there are anti-competitive contract provision bans that I think are pretty favorable to employers. And the Federal Trade Commission has had pretty aggressive actions on non-competes, consolidation, and private equity. And then the Medicare system is, I think, slowly moving towards site-neutral payment policies. Next slide, please. And so that's a lot what's happening on the employer side. I just wanted to highlight, or on the policy side, rather, 3 examples of employers and purchasers that I think are also doing a smart job at innovating. The first comes from the California Public Employees Retirement System, which several years ago recognized the wide variation in prices based on site of care and developed a reference-based pricing program to increase the financial incentives to use an ASC versus a HOPD, which again has prices that are about twice as high. And so what they found is that for shoppable services, spending went down by about 20% overall. And this could lead to about $100 billion savings per year if implemented and expanded nationally. And another example, I think, also comes from the 32BJ Health Fund, which used its own transparency data to recognize that prices that it was paying for a single hospital, New York Presbyterian, were over 300% and actually close to 400% of what Medicare paid, and tried to negotiate a better contract, but faced a lot of pushback. And so developed a targeted network that actually excludes this hospital system. And what they found is that once they excluded that system, they saved $100 million per year, which they immediately translated into worker wages. So the 32BJ Health Fund, which again represents service workers in the city of New York, was able to have the highest pay increase in their union's history, as well as give each member a $3,000 bonus. And so reductions in costs can translate directly into improved financial stability for workers. Next slide. And then finally, the state of Oregon, for their public employees and teachers, recognized that prices were all over the place and not standardized, and again, not linked to quality. And so they implemented a reference-based pricing program that capped prices at 200% Medicare for hospitals. And what we found is that this program in its first 2 years saved about $54 million per year, with no impact on quality of care, access to care, or the healthcare workforce. And so just to wrap up, rising healthcare costs place a tremendous amount of pressure on employers, and in particular, and importantly, worker wages. The distressing view is there's lots of variation in prices that's not linked to quality, but I think this is also an important savings opportunity for employers and purchasers. To achieve those savings opportunities, it's really important that employers and policy or purchasers rather have transparent information on prices that the workforce is paying. And I think policymakers need to catch up and make sure that employers and purchasers have an equal playing field.
Chris, that was awesome. In addition to me dubbing you the grandfather of the Rand Report, I'm also going to dub you the #1 healthcare BS mythbuster. And it's so awesome to have the data. And so thanks for all the hard work to put this together, because it's extraordinarily empowering to, those of us who are out there in the market trying to make a difference. Just quick recap. I think it was your first slide. We spend a lot on healthcare, which comes at the expense of other goods and services. Number 2, we spend a lot because of health prices or high prices. Right? I remember Dr. Reinhard saying it's the price is stupid, right? To all of us, like, hey, pay attention. It's the prices. And then the third one, prices are highly variable, not transparent, and by the way, not linked to quality, right? Because I hear that in the market every day. I charge more because I'm higher quality. Hospitals aren't making as much on this, and I mean, so it just absolutely fabulous. We got a bunch of questions here. You ready to go? Did you get a drink of water there?
Yeah, I'm getting over a cold, but
No, you did great. You did great. All right. So hitting the fiduciary obligation under ERISA. Do you think that this is a little bit of a loaded question, right? Do you think that most employers are actually fulfilling their fiduciary obligation under ERISA?
Again, I don't see how you can be a responsible fiduciary if you don't understand prices that you're paying someone else to negotiate on your behalf. And I think most employers don't have insight to those prices. And so I think a reasonable argument could be made that most employers and purchasers are currently not fulfilling their obligations.
Yeah, that's what I figured. Another one here. So as a broker or consultant, what is my role in the fiduciary responsibility of an employer?
So that's a good question. I mean, I think it's an open question of whether or not you as a broker or consultant also share a fiduciary obligation, or in some sense, whether the employer needs to monitor any conflicts of interest on behalf of a broker consultant. There's a recent provision in the 2021 Consolidated Appropriation Act that requires self-funded employers to obtain any disclosures around conflicts of interest. And so I think the obtaining those disclosures is critical for employers to monitor brokers and consultants as well.
Got it. Yeah. At the end of the day, right, they're advising employers on the decisions that exist within this completely broken system. So there has to be some responsibility there. So several years ago, I was trying to remember how long ago it was. It was probably 4 or 5 years, probably 4 years ago. I remember asking you, based on a slide that you had, whether or not it made sense, because you had a slide and it said employers are paying 227% of Medicare for the exact same service. Does this make sense? And I remember saying, okay, so tell me, does it make sense? And your response at that point was, no, it doesn't. And so I'll ask you the same question now that we're at 254% of Medicare. Has your answer changed?
No, well, no, it doesn't make sense in the sense that if this is something that is linked to better outcomes or quality, then maybe that would, be worth it. Maybe we'd even want to pay more. But given that there's not really any credible evidence that links price to quality access, that's something that for employers who again are financing that higher price out of worker wages makes a ton of sense.
Got it. There's another question for you. Are health insurance premiums significantly lower in low-cost markets like Iowa and Arkansas?
Yeah. So we've so not I haven't looked at Iowa and Arkansas, but we've looked at the comparison between Indiana and Michigan, which again, prices in Michigan are about 175% Medicare, and prices in Indiana are about 300% Medicare. And what we find is that premiums in Indiana are higher than in Michigan. But the other important aspect too is that deductibles are much, much higher in Indiana than Michigan. So it's not just a premium, it's also the generosity or stinginess of benefits as well.
Yeah, because the overall cost is lower or higher, right? I mean, it totally makes sense. I hear this one a lot in the market. Well, we can't make money on Medicare, right? And your data says something different. And so can you say more about whether or not hospitals are making money on Medicare? And then are there characteristics of certain hospitals that are making money versus not making money on Medicare?
Yeah, I mean, so again, Medicare rates are designed to be roughly at cost, and we see nationally that they are pretty close to break even. And so it's a question of being efficient in that payment model. And I guess there's a broader question too of regardless of what happens on the Medicare side, is it fair, using that subjectively, for an employer to be paying not just Medicare rates, which I don't think employers want to be paying, but 2 or 3 or 4 or 5 times what Medicare pays. And that's, I think, where many employers would say, look, we don't want to pay Medicare rates, and we recognize that we do play an important role in financing the healthcare system, but we don't want to pay margins that are 100% either.
Yeah, on the low end.
Yeah.
Right. I mean, back to your slide. Chris, what else should this group? We've got a good diverse group of employers and brokers and consultants on the group. What else should they be thinking about as they go back to their day jobs here in a couple minutes? Like, how do you?
So for an employer, healthcare should be your day job because whether or not again you like it or not, you as an employer, if you're providing health insurance, are in the healthcare business, and so that needs to be a critical part of your organization. And what I think would be just kind of the mindset that employers and purchasers should have is very similar to whether it's CalPERS, the state of Oregon, or the 32BJ Health Fund, the same type of purchasing and procurement and business mindset that they use throughout the organization, and also apply that to healthcare, recognizing that they have an important role in financing healthcare dollars.
That's great. Last question here. Books, resources, things that this group should pick up if they're interested in learning more.
I mean, there's certainly, I feel like I see a new employer doing something innovative on healthcare on LinkedIn, all the time. I think Health Affairs is probably, and especially the Health Affairs Forefront series, just has lots of great information on the healthcare ecosystem, whether it's what's happening on the delivery system side or on the insurance or the employer side.
Got it. And Chris, how do they follow you if they're interested in your work?
Right here. You can shoot me an email.
All right. Yeah, you are in spite of your stature now in healthcare, wonderfully accessible, which we appreciate. And it's pretty cool to think about. And I don't know that many people know that you started off at Castlight a million years ago. And so you've been on this transparency journey probably longer than most people in the country, and have had a huge impact on healthcare and employers and what we pay as employers, and are really out there fighting the good fight. So thanks for your work and your continued courage to drive change in a market that is as resistant to change as probably any that exist out there.
Thanks for having me.
You got it. Thank you, everybody, for joining. Really appreciate your time. And Chris, thanks again.